Well, thank you for joining us here in Austin for the 18th Robert Lee Sutherland Seminar. It means a great deal to us that you're willing to commit your time, energy, and passion to a topic that is so important to the future of wellness and recovery in Texas and the entire nation. We're also very happy to have you here to kick off the celebration of the Hogg Foundation for Mental Health because it's our 75th birthday. Thank you. But we're not officially 75 yet. But it will happen in a few months. But in the past, the Robert Lee Sutherland seminars have been opportunities for us to make note of special anniversaries. And it felt right to launch our celebration in the company of so many of our friends, colleagues, and allies. I hope you will come to the reception tonight for some 75th birthday cake. I would like to thank Dr. Michelle Guzman, our Assistant Director of Research and Evaluation at the Hogg Foundation. As she indicated, she's been working very hard on this. She's done an outstanding job, though, organizing this conference. So please, let's thank Michelle one more time. I would also like to thank Tammy and Stephanie. Please rise. Did you hear that? Well, Michelle didn't have to rise. Stephanie and Tammy are program officers of the foundation, but they also are consumer and family liaisons. As members of the planning committee, Tammy and Stephanie were there at every step of the way, helping to shape the conference and making sure the perspectives of consumers and their families were always vigorously represented. Now, keep in mind, it was a team effort involving practically the entire foundation to put on this conference. We are fortunate at the Hogg Foundation to have such a passionate staff committed to wellness and recovery. It is a process, a very important process. Let me share with you an email I recently received from Ken Thompson, former medical director of the Center for Mental Health Services at the Substance Abuse and Mental Health Services Administration, and now the clinical medical officer at Recovery Innovations in Phoenix, Arizona. Ken had been in town to visit the Austin State Hospital and to look in on their efforts to become a more person-centered, recovery-oriented institution. To say he was impressed actually is an understatement. He wrote, "Over the 3 days I was there, we heard extraordinary stories of vitality, creativity, and tolerance at the hospital, and it's moved away from an approach based on control to one based on opportunities. For the first time, I heard convincing examples of how long a stay at a psychiatric institution could be a sanctuary, an asylum based on person-centered recovery rather than a place of just mere confinement. I saw a place that is becoming more safe by opening up to opportunity and purposefully growing the trusting relationships needed for the hard work of recovery." As one staff nurse wrote, "Our job is to daily build constructive relationships with the people we care for, respectfully attending to them in their full personhood and offering them a choice of meaningful opportunities. The staff, including peer workers and psychiatrists, are electrified with the possibilities. They know they aren't there yet, but they clearly sense they are onto something." Now, I got the email after we had already settled on the title for this year's Robert Lee Sutherland, The State of Mental Health Recovery. I wanted to read from that email because we actually have a team from Austin State Hospital presenting at one of our breakout sessions tomorrow. Where's the Austin State Hospital team? There they are. You'll be hearing from them tomorrow. For those of you who will be attending their session, it's first steps in changing the culture of care. And apparently, they know what they're talking about. I also wanted to read the email because I think it captures some truths that we should keep in mind over the next day and a half. One is what I already mentioned. Recovery is a process. And not just for individuals, but for institutions and systems as well. It challenges long-held beliefs and hierarchies. It is complex and never-ending. It is messy, as most things are that are worthwhile. The other truth, which is reassuring in the face of this complexity, is that essential principles of recovery are simple and human. As that staff nurse at Austin State Hospital said to Ken, it is about attending to each other in our full personhood. It is about moving away from fear and confinement toward trust, openness, and opportunity. In psychiatry, in which I was trained, We're talking more and more these days about person-centered care, or often you hear the term patient-centered care. This can mean different things to different people, though. A number of the breakout sessions tomorrow will explore some of these nuances. To me, however, it is simple. It is about recognizing the autonomy and the individuality of the people we comes to us for help. It is about respecting their values and partnering with them in the plans for their care. It is about seeing them as the prime agents in their recovery, however they wish to define it. It is an ethical construct, in my opinion. You cannot have person-centered care without recovery-oriented care. In my opinion, it just doesn't make sense. Now, why? Because if you're a person-centered, then you're family-centered. And if you're family-centered, then you're community-centered. And if you are community-centered, then you would care about the built environment, transportation, housing, employment, food options, language, culture, and safety. The very issues that recovery-oriented care helps address one and all. Complex, you may think. Yes, as it should be. For guess what? We mustn't forget we are human beings, one and all. And yet, recognizing the simplicity of the recovery perspective is particularly important at this point in time, especially as we move into a more mature phase of the effort to integrate the principles of recovery into the mental health system. It is now 11 years after the new Freedom Commission issued its landmark report. 11 years. It is 8 years since the National Consensus Statement on Mental Health Recovery, and 5 years since SAMHSA's Recovery to Practice initiative. 4 years ago, at the 16th Robert Lee Sutherland Seminar, we brought people together simply to introduce them to the topic, to the concept, to the basic dialogue about recovery. Now we are gathering together to get deeper into the woods and the weeds, and that's a good thing. It is a reflection of how far we have come, but it is also our own challenges. To remember the simple truths, God bless you, even as we take on the daunting task of embedding them in the messy arena of everyday practice. We mustn't shrink away. It is with both of these ideas in mind that I want to take this opportunity to announce 2 new grant initiatives. The ears perk up. Which the Hogg Foundation will be launching within the next few weeks. One will award grants to conduct mental health recovery-oriented research. We will hear about recovery-oriented research from Dr. Larry Davidson this afternoon. The other grant program will support the dissemination of the Recovery to Practice, or RTP curricula, in the fields of psychology, psychiatry, nursing, social work, peer support, and addiction counseling. Folks, did you hear that? Psychology, psychiatry, nursing, social work, peer support, and addiction counseling. That's a lot of disciplines. So I can't wait to hear from Dr. Anel Prim. Tell us about the development of RTP across these fields later this morning. Across the 2 grant initiatives, the Hogg Foundation anticipates investing over $2 million in recovery-oriented research projects and the dissemination of RTP in Texas over the next few years. So let me close by just thanking you again for being here. It's going to be fun to get the details over the next few days and a half. And if your brain gets a bit overtaxed, just remember the simple truth of why we are here. Because we have a vision of a recovery-oriented future. And let me tell you, it is very inspiring. Now, it gives me great pleasure to introduce our keynote speaker, one of the people who are helping to bring that future into being with her intelligence, her passion, her extraordinary commitment to freedom, autonomy, and recovery for all. Yes, I'm talking about Dr. Patricia E. Deegan. She's an independent consultant specializing in research and education about mental health recovery and the empowerment of mental health consumers. She has a PhD in clinical psychology. She's an activist in the disability rights movement and draws on her own perspective of recovery from schizophrenia as an adolescent. She is the creator of Common Ground, a web-based application that helps consumers prepare for visits with mental health practitioners in order to better advocate for their treatment and recovery. Dr. Deegan is also an adjunct professor at Dartmouth College School of Medicine and Boston University's Sargent College of Health and Rehabilitation Services. On top of all that, She is one of the most eloquent and powerful speakers on the subject of recovery that you will ever have the good fortune to see. You will find out in a moment. But just to give you a taste, I want to read a short passage from a lecture of hers titled, A Conspiracy of Hope. She says, "We are a conspiracy of hope, and we are pressing back against the strong tide of oppression, which for centuries has been the legacy of those of us who are labeled with mental illness. We are refusing to reduce human beings to illnesses. We recognize that within each one of us there is a person, and that, as people, we share a common humanity with those who have been diagnosed with mental illness. We are here to witness that people who have been diagnosed with mental illness are not things, are not objects to be acted upon, are not animals or subhuman life forms. We share in the certainty that people labeled with mental illness are first and above all human beings. Our lives are precious and are of infinite value." It is a great honor to introduce you to Dr. Patricia Deegan.
Good morning, everybody. It's a pleasure to be here. It's my first time ever in Austin, so it's a new opportunity. Thanks for inviting me. So I've been asked to reflect on the state of mental health recovery, where we've come from, where we are, and where we're moving to in the future. And I would like to start by sharing a reflection on recovery with you. I derive a lot of inspiration for recovery from just being in nature. And so a long time ago, I wrote a paper called The Sea Rose, from which you just quoted a little bit. And I just wanted to pull that out of the mothballs for a bit and start there in terms of just knowing that in order to understand recovery, sometimes all we need to do is to look around us at the extraordinary world that we live in and listen and learn. So I wrote this paper in the springtime, and in springtime, hope is everywhere. In springtime, it feels like all living things are trembling into being, still wet and new and fragile, and determined to put down roots and grow. And I think of this sea rose I watched growing out at a beach near my home. And it's a fragile and tender life, this sea flower, and I love to see it. At dawn, it moves in a slow upsway as it turns towards the morning star. And that sea rose is a light seeker. It bends toward the light. It is a light seeker whose roots reach way down into the darkness of the earth. In fact, it was in darkness that this new life began. Way back in January and February, when the icy winds lashed across those dunes and the days were short and the light gave no warmth, even then, way down under the ground, this new life was waiting. Nobody could see it. Nobody was there to witness it. And yet, this promise of a sea flower waited. It waited in that icy darkness for the sands to begin to thaw. It waited for the rains to come and loosen the earth. And then, ever so slowly, it began to stir. Moving one grain of sand at a time, it began to grow. Now, it didn't grow straight toward the light at first. No, first its growth sought a downward course, reaching, stretching, blindly groping through shifting sands to find a solid place, a place to be rooted, a good soil to cling to and to be nurtured by, a home soil that could sustain it even in driving rains and tormenting winds. And then, having rooted itself in this way, the sea rose began its journey toward the light. Poking through the darkness, that sea flower emerged tiny and lovely and insistent and courageous, and on frail and trembling limbs this small thing rose to a new life. I think that sea rose teaches us a lot about hope and the way that hope can emerge out of darkness. It teaches us that hope can grow in nurturing environments that allow one to become rooted and secure. And I've come here today to Austin to be with you and to celebrate the hope that is symbolized by that sea rose, because I believe it is a spirit of hope that gathers us here today. It's a spirit of hope that is keeping recovery alive even during times when it's been unfashionable to believe in it. Today, in this audience, we are nurses, policymakers, psychiatrists, people in recovery, peer supporters, social workers, and historically, you would never have found this particular mix of people sitting together in the same room. And I ask myself, what is going on here? Is the foundation shaking a bit? The old order. Is there a conspiracy going on? Now, I like this word conspiracy. It's an interesting one. It comes from the Latin conspirare, which means to breathe the spirit together. And I ask myself, what is this spirit that we're breathing together today? And it is a spirit of hope. It's a spirit of hope because both individually and collectively, we've refused to succumb to the images of despair that so often are associated with mental illness. We are a conspiracy of hope, and we're pressing back against the strong tide of stigma and discrimination that for centuries has been the legacy of those of us who have been diagnosed with mental illness. We are determined to remain rooted in the common ground of our shared humanity and to make that the basis for the work that we do with the people we work with. So we're here to witness that those of us diagnosed with mental disorders can emerge, can grow, can develop our human potential and become the fullness of the person who, like a small seed, is waiting to emerge from within each of us. If we plant a seed in a desert and it fails to grow, do we ask what's wrong with the seed? The answer is no. The real conspiracy lays in this, and that is to look at the environment around the seed and to ask what must change in this environment such that the seed can grow. And when I use this word environment, I use not just the physical environment, but I also intend to connote the human interactive environment, which perhaps of all the environments we inhabit is the most important. So the real conspiracy that we're participating in here today is to stop asking what's wrong with people diagnosed with mental disorders and to start asking, how do we create hope-filled, humanized environments in which people can grow and fulfill their human potential? But before speaking of hope and recovery, I want to begin where I always begin, which is to share with you a bit about my own story of recovery. I want to share with you what it's like to be diagnosed at a young age with a mental illness and to lose all hope for a while. So my story begins as a senior in high school, growing up in Massachusetts. And when I was a young person, I was very good at athletics. Never thought I would have anything to do with academia, or I would never dreamed of coming to Austin to give a talk in front of a big room full of people. In fact, when I thought about my future, I thought about being a lacrosse coach, and that's what I wanted to do with my life. And then I began to have a series of experiences which eventually led to a more prolonged psychotic break during that time between the winter break, Christmas and New Year's. And at the time, I began to experience a terrible fear, voices that were very difficult to ignore, that really felt like they almost engulfed me with terrible messages about me. They were relentless. I couldn't make them stop. I had heard voices at different points in my life, but never like this, never with the intensity. You know, I think we all find it fairly easy to tune out a boring preacher or, a boring teacher, but you can't do that when you're initially experiencing these voices. You can do it later, but initially it's quite an overwhelming and difficult experience, and very difficult to stay grounded in the face of that kind of onslaught. I remember playing basketball with my team. We were practicing during that break, and I noticed that on the court I began to lose all depth perception. I couldn't have any way to gauge when the ball was coming, and I was getting hit in the head with the ball and couldn't play. I left, went into the locker room. My coach came in. She said, I don't know what's going on, but maybe you should go home, and I did. At home, things were scary. They had somehow shifted, and I began to have a developing or growing certainty that the people around me, my coaches, my friend, my family, they may look like my family, but in fact weren't. That somehow some malevolent force had switched them, or something was up, and perhaps maybe I was one of the last humans on the planet. And I didn't quite know why all of this was happening, but you can imagine that it was pretty terrifying to be in that much distress, but also to feel that alone and unable to reach out. Clearly, the adults around me became concerned. I would be barricading myself in the bedroom and shouting back at these terrible messages that were coming my way, trying to make sense of it all. And eventually, the adults around me brought me into a mental hospital. And once there, I was told that I had, once there I was diagnosed with schizophrenia, and I was put on high-dose antipsychotic medications. And I remember being told a little later down the road that I had a disease that was called schizophrenia, and that schizophrenia was a disease that was a lot like diabetes, and just like a diabetic had to take insulin for the rest of their lives, I needed to take haloperidol for the rest of my life, and perhaps maybe I'd be able to cope. The advice I was given upon discharge was to be compliant and to use my medications as prescribed and to avoid stress. Well, I believed it. You know, I was young, and I definitely believed it, that what I needed to do was to take the pills as prescribed and to avoid stress. And so that's what I did. And in those early years, I was very compliant with the medications and with the instructions to avoid stress. I didn't try going on to school and doing the things that my peers were doing and achieving those kind of late adolescent milestones. Instead, I sat on a couch in my family's living room, smoking lots of cigarettes. I became an outstanding cigarette smoker at the hospital. I was sedentary, somnolent, and really what my day consisted of was simply sitting in this chair in a gigantic cloud of smoke, if you can imagine it, with the classic nicotine-stained fingers and nicotine-stained lips, and just staring into space. I didn't need the TV on. I didn't need to talk to anybody, just sitting there. And in some ways, particularly when I was in the hospital, the medications, I felt some relief because at least I could sleep, and getting some sleep seemed really important. But really, otherwise, I pretty much felt like I was among the walking dead. So even though some of my symptoms were less troubling, I was on so much medicine that all I could do was to sit all day and smoke cigarettes and drink this Coca-Cola and stare off into space. And as some of you know, I've come to call this the Coke and Smoke syndrome, you know? And I wish I could say that this was over. And I wish I could say this didn't happen anymore. And I wish I could say that if I went out into Austin or around the state of Texas or Connecticut or Massachusetts or California, that I could find people living vibrant lives where they're optimizing their human potential. But the truth is, I go into a lot of mental health programs all over the world, and what I see still are people sitting in single-room occupancy units, staring off into space in a cloud of smoke. So we have a long way to go. And the stuff I'm talking about isn't just stuff that happened in the olden days. It's also stuff that is still going on. And for me, I was so sedated and emotionally numb that not only was my disorganized thinking gone, but my ability to think at all was pretty much gone. And although my voices were not bothering me anymore, the truth was that nothing really bothered me anymore because I couldn't feel anything. I was somnolent. I slept a lot. I had no interest. I'd not returned to school. I stopped seeing friends, and I sat on this couch all day long. I can distinctly remember a time when my mother invited me into the kitchen. She'd been making some bread from scratch, and she asked me if I would knead the bread dough while she was off doing something else. So I stood over this bowl, and I really wanted, to do this task. And I just stood over the bowl with my hands suspended over it. And I just remember a tear running down my face. It was absolutely more than I could possibly comprehend or do. And just went back to the chair and lit up a cigarette. In effect, I think at that point in my early recovery, I was disabled not by the disorder, but by the treatment itself. I was living out my life in chemical hibernation. And I was maintained out of the hospital like that for many, many months. And my doctor said that I was lucky to be living outside of the hospital, but I felt that I wasn't really living at all. My psychiatrist was pleased with my progress, and he said I was doing well for a, quote, schizophrenic. But my experience was of living in chemical restraints that created walls as thick and as impenetrable as any institution, leaving me isolated from my world and alienated from myself. And I think this image of the flickering TV screen in the empty room really captures what my life was like at that time. I basically was living out my life in handicaptivity. Now, what do I mean? Of course, this word handicaptivity is a play on the word handicap. And what do I mean by it? Well, what I mean by living a life in handicaptivity is living a life in which I had no meaning or purpose, no sense of why I was getting up in the morning or what was important or how I was moving forward in my life. Instead, the only people who were really with me were the people who were paid to be with me, and the only horizon that I lived within was the mental health system. I didn't have a life outside of the mental health system at that time. Life in handicaptivity. So interestingly, I lost years of my life in this netherworld, and although I was treatment compliant and although I was maintained in the community, I definitely was not recovering. And in a peculiar way, my care team, my treatment team, perceived me as a treatment success. And again, I'm being quite serious when I say this, that the fact that by all measures that we still use today to look at outcomes of care, I was a treatment success. I had reduced costs. I had increased community tenure and lowered recidivism. These are things that we measure all the time to judge the success of whether or not treatment is successful. Okay, we're still doing that, mind you. Okay, and yet I was not successful. Now, where was my team coming from? How could they possibly, if they would have come to my family's home and seen me on that couch, or I used to come in every week for med checks with my psychiatrist at the ambulatory care outpatient clinic, and a 20-minute, 30-minute med check. How could I possibly be seen as a treatment success? And I think where my treatment team was coming from is that they understood schizophrenia to be a chronic disorder that had a long-term deteriorating course. And they thought that because they could stop the progression of this inevitable disorder, this inevitable decline, because they'd sort of been able to freeze me in time, And I wasn't getting any worse. And I was not having to use high-end, more expensive services like inpatient or emergency room services, that in fact this was the definition of success. But the way I saw it was that the person, the patient, me, who was now disabled and without a meaningful life. So I was filled with a profound kind of hopelessness, and I really was a seed that had been planted in a desert, and there was no water, and the treatment environment made it nearly impossible to feel like a human being who had potential, who had a future horizon. When I would see my doctor, I would go in for treatment, we would have these conversations. And this is, of course, this slide is me looking back on those conversations, but there was a huge chasm between what I was saying and what my doctor was saying. So for instance, I would say that, I would say that I feel sedated. And my doctor would say, but, you're not psychotic. And I would say, but I'm still hearing distressing voices. And my doctor would say, but you're not shouting at your voices anymore. And I would say, I can't think clearly when I'm on this medicine. And my doctor would say, but you are not thought disordered. And I would say, but I feel like the meds are controlling me. And he would say, no, Ms. Deegan, you are more in control when you're on these meds. And I would say, I'm not myself when I'm on this medicine. And he would say, but you have returned to baseline. And I think that this is a classic chasm. Okay, my doctor and I have not found any kind of common ground on which to stand together and to look forward in terms of where we want treatment to take me. We have no consensus, no shared understanding of where treatment is trying to move. And so therefore, I was, in a way, just spinning in circles. And I think that this gap is still very characteristic of how very often this divide is very characteristic of, again, treatment as usual out in the community. Now, I was working with the brightest and the best of the best, Harvard Medical fourth-year resident, at a teaching hospital in Boston, What was going on? Well, what was going on was that essentially this treatment system that I was in was based on the maintenance model. The maintenance model can be characterized as a model of care that assumes that we're working with people with chronic diseases and in which clinicians make a very guarded prognosis, or there's very guarded hope for remission, not recovery, but remission. And that the emphasis in maintenance-oriented systems, which are very different than recovery-oriented systems, in maintenance systems, there's a focus on meds, manners, and money. Meds, manners, and money, the 3 M's. And I think if I went around Austin and in various places in Texas or Massachusetts or California or Washington and sat in on treatment planning teams, as I often do, sometimes as much as 3/4 of the team can be devoted to discussing these topics. Are the people getting their medication and taking them? And then we perseverate around that for a long time in these meetings. The second thing is, are they behaving themselves? Are there any problems that we need to address? Are the neighbors mad? Are the shopkeepers in town angry about something or upset? And then the third thing, are people getting their checks? And there is an expectation that people will live out their lives on supplemental income, and that that's what we concern ourselves with. We tend in maintenance model systems to put people in supervised congregate living situations. They have expectation that there'll be a lifetime on benefit checks, that folks need to be put in day activity programs that are very often segregated from the community, so that rather than taking a pottery class at the local community college, we put people in specialized programs for people with special needs to do special things like pottery together, as opposed to in a more integrated setting, and end up, I think, with people who are living lives that are devoid of meaning and purpose. And I want to just point out a study that I know many of you are familiar with, where we looked at, Courtney Harding and others, Michael DeSisto from Maine, looked at 2 states that had different sorts of orientations to their system. Vermont had a mental health system that was based on rehabilitation, the expectation that people would become self-sufficient and would work, and the expectation was that people would, leaving the state hospital, would live in real housing indistinguishable from housing that other folks lived in. Where in Maine, we had the classic maintenance model, where the mental health system was based on stabilization. That was the goal. The expectation was that people would live on benefits, that they couldn't work, that would be too much stress for most people. And there was the expectation that people needed to be monitored and supervised and live in congregate settings. And in some ways, there's something that's very intuitively right about Maine's model, about this idea of a maintenance model. Because when people are hurting and when people are vulnerable and when people are struggling, we have a tendency to want to sort of embrace them and care, okay? But what's interesting, so the Vermont system was one in which people were exposed to a lot more stressors, work, integrated housing, whereas in Maine we were sort of doing the maintenance thing. But if you look at the outcomes in terms of where people were living, you can see that across a 16-year period, folks in Vermont were going back to the hospital much less frequently than those in Maine, and that I find that really fascinating, that when people have nothing to do with their lives, when they have no meaning and purpose, when they don't have a reason to get up in the morning, being at the hospital is pretty much as good as being out in the community. You get 3 meals, there are nice people in the hospital too. You know, there's just not that drive to take that extra step that it takes to recover. So what I like to say is that recovery means finding my reason to get out of bed in the morning. Now, this is Bob, and Bob, it has to be, 2 degrees out. And Bob is one of the reasons I get out of bed every morning, because Bob needs his daily walk. Finding a reason to get out of bed in the morning, it sounds really simple, but it can be the foundation of our recovery. Finding a reason to get out of bed in the morning, that boredom is profoundly stressful. So I wasn't a hopeless case. I think I was in a treatment system that had no hope, and there were no pathways to a better life, and I never did hear the word recovery. And so by the time I was 18 years old, I had had 3 hospitalizations. The professionals thought I was now a chronic patient. And you could see it in their eyes. When I first came in, there was hope that here's a young person, who can maybe not come back. But by the time it was 18 and had been back 3 times, I was re-diagnosed with chronic undifferentiated schizophrenia. And people sort of saw me as what sometimes gets called a frequent flyer, which is a very derogatory term that gets used to describe people who return to treatment. I think the truth was that I really wasn't a hopeless case, but rather I was in a treatment system that had no hope, that there were no clear pathways into a better future, and I was like a seed that had been planted in that desert. And when I failed to grow, the treatment system continued to ask what was wrong with Pat. Instead of looking and engaging in the conspiracy, which means to look at the environment around me and say, what's going on, and how must this environment change such that this seed, that this human being can grow. And that's the real conspiracy that we're participating in today. How do we create hope-filled, humanized environments in which people can grow? And that leads me to probably, I've been doing this for a while now, what is the most foundational cornerstone of recovery? And that is the recognition that the people that we're working for are not the problem. the people that we're working with are part of the solution. And I don't know about you, but most of us were not trained to look at folks this way. We were trained to be experts in the diagnosis of disorders. And yet, once we reduce a human being to being a schizophrenic or a bipolar or a schizoaffective, once we've reduced a person to being an illness, then there's no one left to do the work of recovery. And so it's critical that we approach people as full partners in care and to understand that it's only through collaboration and partnership that we're going to move into a recovery-oriented practice. I think this is a new skill set for many clinicians. It's something we're going to have to learn as we go, because it's really not how most of us were trained at school. There was always the opening chapter with the inspiring words about being person-centered and the inspiring words about the importance of compassion and respect, etc. But then we went on to the real stuff, the how to diagnose, how to treat, that we are the expert. We spent all that time and money to get a graduate education. We're the experts, thank you, and we know how to make you better. So let us do our thing to you. And I think what's interesting is even to this day, we still, and I still hear often, where can I find help? Where can I find help for my mental health, challenge? Where can I find help? And it's interesting because there are billions of dollars in programming all around us, taxpayer-funded program all around us, and people are still asking me, but where do you find help? So I like to bring up this cartoon by one of my favorite guys. His name is Scott Chambers. Help! And down comes the wheelchair, because that's what we know how to do. When we drop it, and the guy drowns. Help! Down comes some money. Still the person goes under. Help! Down comes the report on drowning. Right? So the moral of the story, perhaps there are too many reports on drowning and not enough life preservers out there. But also, on a more serious note, help isn't help if it's not helpful to the person receiving services. It's in fact toxic help. It's help that hurts. And what we need to do is to recognize that in a recovery-oriented system, help is co-created. In fact, healthcare itself, I would argue, is co-created. Healthcare is not something that's done to the individual. We don't fix people the same way we fix cars, right? There's a difference. Healthcare is co-created. When a clinician and individuals sit down for a consultation, there are, in fact, two experts in the room. Okay, of course the professional is an expert in their discipline and in the science and practice of their discipline. However, the individual sitting in the room with us is also an individual and an expert. Expert in what? An expert in their history, an expert in what matters to them, an expert in how a medication is affecting their bodies. So when we sit down with people, there are two experts in the room, and these experts need to exchange information and need to comport themselves as co-investigators, looking for that pathway, finding a pathway into a better life. And of course, this process also includes the process of shared decision-making. It's not about me making decisions for you. It's about us looking at evidence-based options and finding out not what's wrong with you, what's the matter with you, but instead what matters to you, right? And making choices about how to move forward. When I think about this, the implications are deep. That the principal source of health care is in fact self-care. And that self-care is the primary source of health care, self-care. Self-care, the care with my family, the care with my community, self-care. And so it becomes really important then to think about this, that I was reading a paper the other day that said that for people with long-term conditions, we spend about 5,000 waking hours a year outside of the clinic. That's a lot of waking hours. In other words, we really are not correct if we think that showing up in the mental health system is going to make us well. Okay, we need to become experts in our own care, okay, so that we can carry that care forth into that other 5,000 hours of our life. That's where healing and health and wellness and recovery are mostly going to happen, right? And so that as clinicians then, and as researchers, we need to start getting concerned and begin to think about how to measure the success of treatments' impact on individuals' self-care confidence and self-care competence. How well are people able to manage their disorder and make progress in terms of reaching their human potential in these other 5,000 hours? These are the outcomes that ultimately matter. And so, you know, as I look forward into the future of mental health services and behavioral health, we're all aware of a big push to begin to integrate health and healthcare with physical health care with mental health care, and there is no health without mental health, and there is no health without physical health, and they all go together. Great stuff, really important. It's great that we're starting to look at people more holistically. But frankly, when I think about recovery and what's coming in the future, I am a little concerned. Yes, it's important to save lives. Yes, it's important to help people get the physical health screenings that they need. Yes, we recognize this now. Okay, but what worries me is that as treatment shifts over to physical health, and we're getting people with psychiatric disorders are getting primary care in traditional primary care practices, that we're going to lose the notion of recovery, and that mental disorders are just going to be seen as one kind of illness among other illnesses that primary care practitioners treat, and that the treatments will only be somatic, and that worries me, that we may in fact lose the incredible progress we've made with recovery. And I really do wonder about the importance of having peer staff, paid peer staff present in primary care as we begin to shift folks over in terms of service deliveries, to have peer staff in federally qualified health centers to ensure that these new staff, these nurses and these docs, are getting exposed to the notion that recovery is not so much about what you take but what you do. And so for me, personal medicine has been a key to my recovery. And by personal medicine, I mean the things we do to get well and to stay well. That personal medicine is a disruptive notion because it gets to the notion that simply swallowing medications is not enough to make a recovery. That recovery requires us to get active and to begin to do things differently. So let me give you an example from my own recovery. I mentioned that voices were pretty difficult and overwhelming in the beginning of my recovery. And what a lot of us find is that by creating a synergy between what we do and what we take, between our personal medicine and the psychiatric medications we may use, that it creates a synergy or a cascading effect that can begin to launch us forward into our pathway of recovery. So as I told you, I was pretty overwhelmed with these voices and found them very difficult to deal with. And over time, I began to stumble into ways to manage them. I'm old enough to have had a Sony Walkman with an analog tape in it, and that became quickly my best friend. Because what I found is when I listened to music, the voices became less intense. And actually, the music helped to distract my attention away from the voices. And suddenly, I can't tell you what that feels like, to actually do something that makes a difference in what these all-knowing, all-powerful, all-seeing voices are up to. I could put on these headphones, listen to some music that I liked, and I didn't feel as overwhelmed. I could get distracted. I had power. I was empowered. I could do something. And it just was a life changer for me, being able to do something that actually impacted these voices. And so I began to learn some of these skills, and as I would share some of them with my psychiatrist, we began to lower my medications. And as we began to lower the antipsychotic medications, I was able to have more energy. And once I had, and I'm not talking massive amounts of energies, but at least I had some energy. When I had some energy, I was able to begin to exercise. Not play lacrosse again, but at least get out for a walk, okay? And once I was able to get out for a walk, I was able to sort of release some of the tension that I was experiencing, which meant that I could sit still and sit quiet for a little while. I was able to meditate and pray, which was something that had always been a part of my life. And the more I was able to meditate and pray, the stronger my sense of self became, okay? And of course, the stronger your sense of self is, the more possible it is to develop even more kinds of personal medicine to manage voices. So the way I look at it is that recovery means changing our lives, not our biochemistry. Okay, recovery means changing our lives, not our biochemistry. But up comes this gal, and she kind of goes, oh, dang, I love this gal. Sun's rising, she's got a strong cup of coffee. Right? And she's kind of saying, dang, I wish it was true that all I had to do was to take the pills. Wouldn't that be wonderful? That really, if there really was. But she's like, I've got to change. How many people have a few things on their personal change agenda in the room? Yeah, we're not all doing it. It's hard to change. It's hard to change. And recovery means changing our lives, not our biochemistry. It doesn't mean showing up to get fixed. When I have really bad sore throat and a fever, and I go into the doctor, and I get diagnosed with some sort of strep throat or something, I take a medication, an antibiotic for a few days, and I'm back to myself. I kind of wish mental health worked that way, but for the most of us, that's not how it works. So recovery means changing our lives, not our biochemistry, and at what point in the care system do we get that message across to people? I would argue it has to be from day one. That sitting here swallowing pills, sitting in a chair is not enough. What is your personal medicine? And helping people develop their personal medicine. Let's take a minute to hear from Sylvia.
Hi, my name is Sylvia, and in 1991, I was diagnosed with major depression after a suicide attempt. Today, I want to talk to you about my recovery. I am happily married for 8 years with my husband. I have raised 3 children, and now I have 8 grandchildren. I want to talk to you what has the turnaround in my life after attempting suicide and my relationships. My personal medicine that I have encountered has been garage selling. I have this that I treasure, my jewelry, and that's because most of it I have found in garage sales. You would be surprised what you find out there. And what I started was, I'm very good in finding things at garage sales, so I started a booth at the flea market. I encountered this challenging, so I went from 1 booth to 2 booths, and now I have 3. I'm always anxious to see what kind of jewelry I can find. I always want to go and see what I can find to put in my booth. This has helped me not to remember my illness. I keep going to see what I can find, and this is something I cannot deal with a job because I get stressed out, I get angry, and this has helped me to cope with it and still support myself. And this has been the greatest thing that I have found. You can also find it. You can also find it in the sense that you can look for something your personal medicine. It could be also in a game. This has been a challenge to me. I have gone from beginners to super tough. And right now I'm doing a hard. But you know, if I can do it, if I can do a simple game and be a challenge to me, you can too. You can find your challenge and you can find your recovery.
So my point, I hope you get my point here, that I've read, you know, my share of textbooks in psychiatry and psychology, and there is no way I could have forecast that garage sales and the would have been the ticket for Sylvia. That we need to look at the people we're working with not as the problem, but as part of the solution, to invite them to the table and to discover together how they can harness their human resilience and their interests and their resources to come up with extraordinary, unanticipated, novel solutions and find that pathway into the life that we want for ourselves. That's what recovery is. So today, my personal medicines show some of them up here. You know, I've got a great family. I've been with my partner Deborah for over 25 years now. We have a delightful 17-year-old daughter named Cheyenne. Powerful personal medicine gets me out of bed every day, keeps me going, brings great joy to my life, and underpins everything I do with just a real sense of meaning and purpose. That's me hiking above the Arctic Circle in Norway. They actually have a university up there that I got to give a lecture in, so I did some hiking. Nature just continues to enthrall me with its magnificence, and of course, doing the work that I do are all part of my personal medicine today. And it's amazing when I look at this slide, you know, when I look at this slide and I look back to the day of my early recovery, and in my early recovery I couldn't stand people. I just didn't want to be around any of you guys. I was like, everything at arm's length, you know? But what's interesting when I look back on that time is that people took the initiative to relate to me, even though I didn't want anything to do with pretty much anybody. But it felt good when things got particularly scary to know that if I needed to, I could reach out and there would be a friend or there would be, you know, a sister that I could relate to. And when I think back, this thread of being related to people was very fragile and it needed to be nurtured over time. And I just want to share with you know how it is that I actually began to get active in my own recovery. When I left off a few minutes ago, I talked about the fact that I was sort of stuck in this chair smoking cigarettes for way too long. But the thing that was interesting is that every single day my little Irish grandmother would come in the door to the room I sat in, and every day she would ask, Patricia, would you like to go food shopping? And I would say no. And she would come in the next day. Patricia, would you like to go food shopping? And I would say no. And I said no for many, many, many days, long time. But she was, I think, a very wise woman. And she didn't come in 5 times a day or 10 times a day. She came in once a day, and she invited me once a day. And one day, for reasons that I truly can't account for, I said yes. And then I added the caveat that I wouldn't put a darn thing in the shopping cart, but I would push it. And so there I was. The first active step that I took in my recovery was pushing a cart down the aisle of the A&P in Cohasset, Massachusetts. You know, that was where the journey that has led me to Austin today began. And as part of that journey, I think back on, you know, why was this thing my grandmother doing? How did that work to get me kind of started? And when I think about it, of course, she only asked me once a day and not 10 times a day, because that would have been nagging me and I would have shut her right down. But I think that she also really, in that invitation, was saying, Patricia, there's a door. Patricia, there's a door with a threshold that leads to a world. Patricia, there's a door with a threshold that leads to a world that can be for you, that can be a good world, if you can take that step, if you can take that step into that world. And the fact that that invitation was there every day, and at some point, and I think this has to do with the grace of recovery, the part that we'll never nail down in a survey or a research project, that grace, that moment when I said yes. After that, it wasn't too long after that, sort of got a little more interested in the world around me. Also began a single course at a local community college. You know, and I had my plan. I knew what I wanted to do. I had been in my doctor's office around my third hospitalization, I think it was, and you know, once again, he was doing the thing about how I had to avoid stress and had a disease like diabetes, and was trying to talk to me about going into a group home in Brookline. And I remember something rising right up over the top of the haloperidol, and something inside of me just went, you are so wrong about me. You are so wrong about me. You're just wrong. It's not that I lack insight into the fact that I'm ill, it's that you lack insight into the fact that I'm resilient, is what I would have loved to have said at that moment, but I didn't have my wits about me. But I remember that strong, powerful pushing back and going out in the hallway, and this thought came to me. And this is exactly what the thought was. It was, you know, you're wrong about me, and then it was, and so I'm going to become Dr. Deegan, and I'm going to change the mental health system so no one ever gets hurt in it again. Now, that's an amazing statement for an 18-year-old to make. Well, I have to admit that 18-year-olds get to think those large thoughts. And I know today, with my maturity, that in fact I alone am never going to change this mental health system, that it's going to take all of us working together. In any case, that became what I call a survivor's mission, or a vocation, a calling. It's how I feel I was called in this life, who I was called to be. And each day I get up and I say yes to that calling. And there are days when I'd like to walk away from it, because it's not easy to do this work. I think you have to be a little strange to do this work. There are definitely easier ways to make a living. Nevertheless, I say yes, and that is what I do. Now, without a doubt, recovery is what I call a disruptive innovation, and it's a disruptive innovation on many levels, both in present time, but also historically. And since I've been asked to take a little look at history, let me just share an interesting story about the birth and the of recovery. So Worcester State Hospital in Massachusetts was the first publicly funded state asylum for the insane in the United States. It opened in 1833, and Samuel Woodard was the first superintendent. And the practice at the asylums were developed with the most amazing and in many ways modern of intentions, to use moral treatment, to recognize the power of kindness, no physical restraint or shackles, the importance of work, and the importance of exercise and nutrition. And the goal of treatment in the early asylums was recovery, okay? And they openly used this word recovery. In fact, there was in 1881 a study that was actually conducted of folks, 1,157 folks discharged as recovered from Worcester State Hospital. So they did this follow-up study, and the findings were remarkable. That in a day before medications, in a day before CBT, recovery rates were very high. So 317 people at the time of their reply had remained well and had not returned to the hospital. and that 251 additional people, although they had passed or were dead at the time of the survey, had remained well throughout their lives and had never returned. And that the recovery rates through moral treatment at Worcester State Hospital in the 1880s was that 58% of those discharged remained recovered. So recovery is not a new idea. It's not at all a new idea. And yet there was resistance to the very idea that people could get well, be discharged, get well, and stay well for the rest of their lives. So here's how the Board of Directors at Worcester State Hospital, the Board of Overseers, interpreted the results of this study. They didn't, at that time, want to hear that people were doing well. So instead, in the annual report, interpreted the findings to mean that there can be no doubt that the public have been hitherto widely misled as to the meaning of the word recovery as used in the hospital reports and as to the permanency of cures from insanity. Not a small number of patients who were discharged, recovered in earlier reports of this hospital, have many times since become a burden to the public or private purse by reason of return to their malady. In other words, they're saying these data, it's almost like is the cup half full or cup empty, and it's empty. Recovery is not real. And instead, at that point in history, there is a quest for cure, replaces the quest to help support people in their recovery. The majority of the insane are not likely to, and as a matter of fact, do not recover. And the judgment of the medical profession further advance in our knowledge of the pathology of the structural changes of the brain is best assured in the revelations which the microscope will furnish. Okay? And there's a major shift there. We see recovery being pushed underground. And so, like the Sea Rose, recovery endured a very, very long winter. There's your very own Austin State Asylum back in the day. And of course, in Austin and all over the United States, these institutions became places to warehouse human beings that were devalued, marginalized, and many lived out their lives. And when you start dealing with, 8,000, 7,000 people in a single institution, recovery rates plummet. So the good news is that through the consumer survivor and ex-patient movement, recovery has reemerged in the 70s and the 80s, okay? And our voices have been loud and have been clear. We do recover. We are the evidence, okay? And we're not letting go of that message. And that's part of what is bringing us today. And what's really beautiful is that we have met many allies, many mental health professionals, policymakers, researchers, who have also defied the great tide of history, pushed back, and said that we too can see that recovery is real, and that we want to enter into solidarity with this recovery movement so that people have the opportunity to live lives of deep meaning and purpose. And so we're on our way, and we are a force to be contended with. And I'm committed, as I'm sure you're committed, to never let recovery be pushed down under, as it had been in the 1880s. That we're going to keep it alive, we're going to keep it out in the forefront because, again, we are the evidence that recovery is real. Now, in terms of my work, I want to take a moment to tell you a little bit about what I see as some of the future and how, in my work, I'm contributing in my small way to that effort. We are in a historic window of opportunity. It's like heads up time, guys. We really got to be alert to this. There's a lot going on, I know, but I'm going to tell you about the part that I'm working on, okay? And the part that I'm working on and I'm really concerned about is that right now, as I turn towards the future, what I see happening is the proliferation of electronic health records, okay? And the thing about these electronic health records is very often they are simply taking various sorts of paper and questions and forms and converting them to a digital format and clustering them together along with a billing system into an electronic health record. Now, the reason this is important, here's a typical screen. I don't even know what product it comes off of, EHR, but you are not going to find the word recovery in most electronic health records. It's not there. It's not there. So what this means is that where we're heading in terms of modern practice is that people we've introduced a new environment, a digital environment, and clinicians are spending a lot of time in it. They're spending a lot of time, as they talk to us, they're at that keyboard, and they're entering data. But they're entering the data that they're being asked to enter. And too often, the data that they're being asked to enter is sort of the old, not person-centered medical model kinds of text fields. So people are entering data about problems and deficits and symptoms, and you just simply don't see the word recovery. Let me ask you this question. When a clinician you may be working with sits down at their computer in the morning and opens the home screen of that computer, what percentage of screen real estate should be your voice, my voice? My friends, it's not there, your voice or my voice. We may be a tab at the very far right of the screen that says other or strengths, maybe. This is a problem, because what we're doing is we're digitally hard-coding old practice. And just so you know, it's not benign, that because clinician workflow gets engineered through the forms they have to fill out as they're working with us, there's no prompt to ask about your personal medicine in there. So are you going to get asked about it? Maybe not. Right? And this worries me. Where is our voice? So I started a small technology company run by and for people in recovery, because my mission at this point in my life is to get the voice of us, family members and people in recovery, into the health record. I was doing an interview the other day, and I said it's like what I'm trying to create is a stack of Jimi Hendrix's Marshall amplifiers to blast our voice into a very difficult consultation. There are 17 tasks that psychiatrists routinely need to perform within the context of a Medicaid reimbursable med check. Everything from establishing clinical rapport to doing symptom screen, side effect screen, substance use screen, trauma screen, appropriate documentation, and labs. Research says that when we first sit down with a doctor, and the doctor asks very nicely, "How you doing?" You got 18 seconds. That's a fact. In 77% of the interview studied, it's 18 seconds before you're interrupted. And imagine on top of that, being very depressed and having trouble speaking, or having a day where you're feeling disorganized. How do you answer in 18 seconds or 2 minutes or 3 minutes within a 15 to 20-minute medication consult? And so that's what my work is about, because I don't think, at least in my lifetime, that CMS is going to say, hey, let's extend MedVisit. Probably not. Probably not. Okay, so how can technology help? So people in my company are all people in recovery, and we're committed to making sure that the voice of individuals and families are amplified within these new digital environments, so that recovery doesn't fade out again, okay? These environments are very important. So our vision is that in today's healthcare environment, there is no time for waiting in waiting rooms. We got to get rid of the waiting rooms. There just isn't time. We've got 15 minutes. We've got 20 minutes. And in that 15 or 20 minutes, extremely important decisions are going to be made that will affect our health and our well-being, okay? We need to prepare to participate in a process of shared decision-making. We need to learn how to engage in our self-care so that we can recover. So the way this technology works is that prior to the appointment, whether it's from the field on an iPad, from home, or from the clinic, people prepare a one-page health report. And in that health report, it focuses very much on recovery and recovery progress and obstacles to recovery. And here you see someone preparing their health report. And then we meet with our doctor, and the doctor can see the health report on the screen as well, learn about how our recovery is going. And what's kind of cool is we've moved beyond the point of this being just a prototype. We now have over 58 sites using this technology in 8 states. And what we find with over 21,000 users who've created more than 107 health reports is that shared decision-making, person-centered practice can measurably happen within 15 to 20-minute med check visits, at least 68% of the time. Really proud to say that a little tiny company of people in recovery trying to make a difference are starting to get some recognition, including the 2013 American Psychiatric Association Psychiatric Services Gold Achievement Award. But also what we're doing is we're pioneering a whole new role for peer supporters. A lot of times what's happening out there are peer supporters and paid peer practitioners are struggling to find a unique role in the service system. And part of what happens with the technology that we're using is that we get rid of the waiting rooms, and instead we have iPads or we have touchscreen computers. And when you come to Med Clinic, guess who greets you? A person in recovery. Offers you a cup of tea. Assists you, supports you, encourages you, entices you to use the technology, to communicate your concerns. So peer staff have been sort of the heart and soul of rolling out this technology, a whole new, unique role, peers supporting peers in having a different kind of conversation, because the technology helps people have a very different kind of conversation. So the first thing that people do is they put their they're helped to discover their personal medicine, and they put it into the software. Every single time my case manager, my therapist, my doctor, my nurse sees my health report, they see what my personal medicine is. Secondly, when people use the technology, they're assisted in creating what we call a power statement. A power statement links the clinician's treatment plan with the individual's recovery goals. That's an unbelievably important thing. It's not focusing just on symptom reduction at any cost. If I'm so drugged up that I can't be with my family, what good is treatment? The technology helps the treatment team focus on what's important to me in my recovery. Here's an example of a power statement. Every time you use the technology, you update your power statement so your team knows what matters to you. The most important thing in my life, doctor, is working at Pizza Hut. And I want my medication to help me focus on my work, not my voices, so I can pay attention at my job. I want you, doctor, to work with me to stay out of the hospital so I can continue to work at Pizza Hut. If this guy is not working at Pizza Hut, treatment has failed. We have squandered public dollars, okay? This is about helping people achieve their recovery goals. And not only that, so that all of that's entered into the computer and the whole team can see it, but also, while doing a health report, you can watch 3-minute video vignettes of people in recovery from substance use disorders, people who've learned to manage health disorders, and people who are living in recovery. And I did this very strategically. I don't want us to have to rely on staff being able to convey an accurate message of recovery. Nearly everybody in mental health systems comes to Med Clinic. And Med Clinics using this technology, every single person has the opportunity to hear that recovery is real. And these 3-minute video vignettes are going to make sure that the message of recovery never gets lost again, because we can do it just right peer-to-peer through the technology. People using the technology can explore their own recovery. They can explore their own data. They can ask questions like, how is my use of drugs and alcohol affecting my ability to sleep? Okay? And learn. And not just us, but our case manager and our therapist and our doctor can also learn. And then there's an extraordinary library in the software in which people can learn about when to talk to a doctor or nurse about reducing mental health medicine. They can learn about managing weight gain caused by medication. They can learn about love and romance in the context of recovery. How do you tell if you're in an abusive relationship? How can you tell if you're in a healthy, strong relationship? How can you tell if you're having sexual side effects, but the meds are really working for you? How do you manage that, in the context of a relationship? So my sense is that we need overall to safeguard our conspiracy of hope. We need, and these are the fundamental principles, I think, to engage with people, not with illnesses. We're not the problem, we're part of the solution. We can lead meaningful lives even though some symptoms persist. The goal is not symptom abatement, it's functional recovery and achieving our human potential. That self-care is primary care, and that help is co-created. That cars might get fixed, but we heal and grow. That medication should support recovery, not disable us. And that everybody needs to begin to discover their personal medicine in order to make their journey of recovery. So how do I define recovery? I define recovery as a pathway into the life that I want for myself. And I want to just say that recovery really doesn't refer to some kind of end product or end result. And it doesn't mean that I'm cured or that anyone is cured. Today, I still use psychiatric medications as part of my recovery, but it's just one tool among many tools. And I don't think I have some dark disease that's waiting at any moment to come back. I know too much. I'm too skilled and talented. In fact, the way I look at it today is I live with certain kind of vulnerabilities, okay? So if I'm on a long flight from Austin to Boston, I know I'm going to hear voices because I hear voices in white noise situations. I don't get engulfed or overwhelmed by that experience. I know how to manage it, and I can anticipate it and make it through it just fine. And if I struggle, which sometimes I still do, I have friends and family to support me. And so recovery doesn't mean being somehow magically cured and without distress. I think the big lesson I learned is I used to think I was the one that had to get normal, and then I got to know some of you normal, neurotypicals. And I went, whoa. Yeah. So we're all living with vulnerabilities, and we're all making our way through life, which sometimes is not always easy. So in closing, let me just say that recovery is a process. It is a way of life. It's an attitude, and it's a way of approaching the day's challenges. And it's not perfectly linear, and like the sea rose, recovery has its seasons. It's time of downward growth into the darkness to secure new roots, okay? But that's not the end of the story. There's also the times of breaking out into the sunlight. But most of all, recovery is a slow, deliberate process that occurs by poking one little grain of sand at a time. It requires patience. And so, as the sea road teaches us, this work of growth is slow and difficult, but the result is beautiful and wondrous. And I think we've chosen very difficult work. And as I said, I definitely think you're weird for choosing this line of work. But we stick with it. And I ask myself, we do stick with it, and we're faithful to it. And why? Because we are a conspiracy of hope. And we see in the face of every person who comes for help a life that is just waiting for some good soil in which to grow. And I know those of you in the room today are committed to creating that good soil. So let me just take a moment and celebrate you. and to celebrate the strong and fiercely tenacious spirit of those of us with psychiatric diagnoses. Let me celebrate the person within each of us. I celebrate our conspiracy, and I'd just like to say that I think all of us deserve a big round of applause. Thank you. Very good. So I was asked to take questions for about the next 10 minutes or so. So folks, comments, questions, thoughts? Not sure if there's a mic in the room for that. There's one here and a mic here. If people would please use them, it'll help everybody here.
I was very intrigued by your program, and just wondering how easy is it to take that report and integrate it into the provider's EHR?
Well, that's a great question. It's pretty easy to integrate it into the provider's EHR. And my question is, like, why aren't the EHRs having this at the very center of it? The way I see it is these EHRs need to have our voice at the very center, and then you build the health record around our voice and the voice of our families and friends. That's where I think the question is. Where's the EMR company that wants to build around the voice of the individual? Hi.
What would you say was the hardest part of your recovery, and why?
Can you repeat the question?
What would you say was your hardest part of your recovery, and why?
That's a great question. Well, I make a big distinction between early recovery and then kind of my ongoing recovery, right? And I think in my early recovery, the most difficult thing was making these discoveries that I sort of made on my own, which is that I had to speak up, that I needed to learn about personal medicine and the things I could do to help myself get well, that just laying there and being drugged wasn't going to do the trick, that boredom is stressful. These were all keys to my ongoing recovery. And I think as my recovery has progressed, I find myself having to deal in a more very focused way with issues of childhood trauma. And I know that people with histories of childhood trauma are way overrepresented among those of us with diagnoses, and I'm not different in that way. And so taking on the challenges now of healing from this trauma, it's interesting, my doctors knew about it because, it's documented and stuff, and it was all in the record, but they felt that I didn't have the, quote, ego strength to deal with it. I remember trying to bring it up, and I said no. And so it's taken me some time to have the energy. And I think the big lesson that I've learned there is until I have my feet firmly planted in the here and now with my reasons, and there are many of them, to get up out of bed in the morning, that it's not the time. Until I've achieved that, it's not the time to turn and look back at those horrors, right? You need to have a sense of your life opening on to a rich future in order to be able to look back. And so that's the challenge I'm living with now, is coming to terms with this and wondering, or just being on that journey of healing from trauma. Yeah, thanks for asking. Yeah, hi.
Yes, hi. I have a question. What would you suggest for families that have, that may be dealing with someone that has the diagnosis of the mental illness and are not focused on taking their medication, and they end up back having those same episodes? What would you suggest to them? I just wanted to know if they should take them to a treatment home, or if they think that, keeping them at home themselves and following after them is the best thing. What do you suggest?
So learning to use psychiatric medicine in your recovery process is really a journey. You know, it's really a journey, because although these medicines can be helpful for some people, they also have unwanted effects that can be very difficult to live with.
Okay.
So for instance, I do a lot of consulting with first episode psychosis teams, young people having, you know, from 14 to 24 that are having their first psychotic episodes. And what we've learned is that just kind of saying to people, you've got to take meds, and just focusing on that really tends to alienate younger people, and they don't want to take on that identity. But what we're finding through some of the qualitative research we're doing with that group and that effort is if you engage people around where they're trying to go in their life, if you engage people, I want to have a girlfriend. I want to have a group of friends. I want to return to high school. I want to go to college. I want to become a mechanic. And if the team can embrace that dream, that hope, that goal up front, then medication becomes a means to an end rather than an end in itself. And that's a huge shift in mental health that we got to make, right? But also remember that learning to use medications is a journey, that it's not a crazy thing to say, I don't want medicine. There are some very rational, important reasons why one might choose not to use medicine. That said, some of us have to make trade-offs. I don't want to use meds. I've never wanted to use them. I kind of hate them. But you know what? They help me get where I want to be in my life. And there have been times when I've been off them and done just fine, and there are other times when I use them again. So I think that's the way to approach it. And I think that this process, which I don't have a lot of time to go into today, called shared decision-making, is an extremely respectful way of collaborating with people on this journey of learning to use medication optimally in my recovery process. So scolding people, punishing people, cajoling people, you know, all of that stuff that sometimes we do because they're non-compliant really seems to be counterproductive, in my opinion. Collaborating with people around discovering their own personal motivation for using meds. The judge wants me to use it, my family wants me to use it, you know, my doctor wants me to use it. What's my reason? Discovering that is the key to using meds effectively, but also discovering your personal medicine and the other things you can do to create wellness is part of it too. And just to put this out here, because sometimes people mishear me around personal medicine, I am not suggesting that for everybody, personal medicine, just use personal medicine and don't take psych meds. You know, that hasn't worked for me, you know, just to speak personally, okay? It's finding that balance between what I do and what I take that opens a pathway into recovery, not for all of us, but for many. And I also want to say that those of us who use psychiatric meds, my recovery is no less than a person who has used them and now doesn't use them anymore. It's not a moral thing. It's a very pragmatic thing. What works?
Thank you.
Yeah, good. I'm sorry. I'm supposed to go to this side now. Hang on.
I work at the jail in Harris County. Paul and I are there, and there's been an emphasis on trying to shorten the length of stay, you know, on the mental health unit, shorten the length of stay. And so one of the issues then that we have is how to build that rapport and trust that we need with those patients with, you know, if we're trying to shorten that length of stay. I just wondered if maybe you had some insight or suggestions or ways that you have seen to do that.
To shorten lengths of stays?
No. To build that rapport and trust that we need in that short length of time.
How short is short?
They're trying 7 days.
Oh, yeah, that can be difficult. So we have one recommendation I have. I think what helps to build rapport is to get a sense of what matters to this individual in their life. It may be that they have a baby, it might be that they have a partner, it might be that they are supporting or a great cook for their family. What really matters to this individual, and connect at that human level. You know, that's rapport, the common ground of your shared humanity. And so what we find, like when we're using this technology, is a lot of doctors and nurses who've known people for years, when they see somebody's power statement, are kind of shocked because they never knew that working at Pizza Hut was the most important thing in their life, for instance, and that's what we should be talking about, and that's what matters. So that's the key, I think, even in a short-term situation of 7 days, is finding out, you know, what matters and being willing to recognize that if somebody shares that with you, what a precious gift. And that we don't damage it and we say, oh, that's wrong, but rather we just receive it as a real type of sharing. That helps. Yeah.
I'm very interested in your videos. I see from the slides that you had videos on your website. If we wanted to play them on a hospital TV channel, do we have to get permission or is there a cost?
Well, the videos are all built into the technology, right?
Okay.
And so if you wanted to, you know, sort of beam them into, they're not just sitting out there on the internet. If you go to, you can see here, we have a Facebook page. Oh, darn, if you go to YouTube and you search Pat Deegan, you'll find bunches of my videos up there. And you're free to stream those anytime, any place.
Okay, great.
Yeah,
Okay.
good.
I'm not sure how to ask this, but when I first went into treatment, I told my provider that I wanted my house blessed and cleansed. And then later on, I had a crisis again, and I told him one of the people I wanted to see to help in my crisis was a good undead. And each time I said that, what I said was met either very negatively or with silence and not acknowledged. So how would you say that we can bring different, I guess, culturally diverse practices to where they're honored and seen as part of important to a person's treatment?
That's a great question, and we, I think, have to always remember to be open to culturally diverse viewpoints, worldviews, practices. You know, sometimes what I recommend is to go to someone with expertise in that area. You know, if you want your home blessed or your belongings blessed. I remember a guy who even, you know, wanted to get his medications blessed. But a mental health professional is not going to be the one who, I'm serious, So my recommendation is to go to someone who, within your community, is recognized as an expert and a leader in that particular practice. And we need to remember that mental health professionals can't be experts in everything, you know. And so in the case that I'm talking about, the case manager helped the person go to the pastor at his church who was willing to bless his medications, and it just made all the difference for him in terms of being able to and willing to use them. So just a thought. I think my time is up.
I have one quick question. You want to take these last two quickly?
All right, I promise to take these quickly.
Okay. Mine is a two-part question. The first question is, when a person is in an acute setting and has been gone through the emergency room and the person comes down and diagnoses them and says, yes, they need to be hospitalized. The person is not really informed on what's going on. There's no one there to really convey anything of what's going on and what there is actually happening. And so they're thrown into this situation, and then they're thrown back out into the world with no connection and no resources other than, well, you have a doctor's appointment or schedule a doctor's appointment and follow up on your own. And that's in the public setting. What I would like to see is a movement to where I have noticed that more and more ECT treatments are being provided to patients inpatient. They are put on medications and then they are said, here, sign this piece of paper, and then the next day they're taken for ECT treatments. They don't know what they're signing and they don't know what they're doing. The second thing is, yesterday I had a woman come up to me and was having hallucinations and auditory hallucinations. And I spent 3 hours with her. Her main concern was, I don't want to go back to the hospital because I had such a terrible treatment there and I'm scared to death, and so I don't want to tell anybody that this is going on. And so I talked with her. I asked her, call your doctor, let me talk to your doctor. I walked her through the steps. We got her calmed down. We made a plan. We did this. I had her check in with me every hour, and by 7:30 that night, she said, I'm feeling so much better and I'm more confident, I'm relaxed, and I'm understanding where I'm going. I have an appointment tomorrow morning with my doctor. And so we prevented her from having to go to the hospital.
Yeah.
And I just wish that in more acute settings that there is a peer that is available to assist somebody so that the trauma of the clinical setting is not engaged.
Yeah, thank you, I agree.
Can you hear me? Have you had the opportunity to work with any recovery-oriented psychiatrists? And if you have had that opportunity, can you describe what that's been like to work with recovery-oriented psychiatrists?
Well, I work with recovery-oriented psychiatrists now as a colleague, but do you mean me personally going for? Yeah. Well, I mean, psychiatry is an extraordinary profession, and within it, like any profession, there are just outstanding practitioners, and I think that they're really. It just makes a world of difference to have someone who's willing to engage with the whole person as opposed to trying to treat an illness. And there's just such a huge difference in the orientation, how you talk, how you think. And that's, I think, what Recovery to Practice and the Hogg Foundation are interested in supporting, is how to help clinicians who have the best of intentions actually be able to transition into working with an entire person as opposed to just treating illnesses. So, yeah, thanks. Thank you, everybody.